Good evening, everyone. Anyone? I must admit it's a little disconcerting sitting in front of a computer, not being able to see my audience. Usually I'm able to see who's sleeping, who's not paying attention, who is paying attention, who's fiddling with their cell phones. In this instance, obviously, COVID has done us a great favor, but there is no integration between me and an audience. Nevertheless, I'm going to assume that there is at least one of you watching this program or this presentation, and I'm going to be speaking to you. I've chosen to record this presentation because we do not have fiber where I live at the present moment, and to try and make sure that the quality remains optimal, I'm recording it and submitting it, and therefore I'm not going to be doing this live. So let us get down to what we are going to be talking about. I'm going to share my screen. Give me one moment. And let us go. As a profession, optometry should or does understand diplopia, or at least we think we do. But you'll see in a little while that perhaps we do not understand a diplopia as well as we might want to. And so we're going to go through some of the definitions of what diplopia is and how we look for it and what we do about it when we are presented with this conundrum in our practices. Firstly, you need to pay attention to what I have to say, because not all the multiple choice questions have the answers in the slides. So I'm going to say things which have questions related to them, and you're going to have to remember what I say, or perhaps go back through the presentation, but they're not going to be anywhere in the slides, so attention is going to be required. The first thing we need to do is define the word diplopia. What is diplopia? So I'm going to give you a minute or two to read through these three definitions that you see on your screen at the present moment, and then we will discuss them. And the last one. If we go back, the first definition is, in my view, not optimal, in that it suggests that you have to have two eyes. When the disparity between a pair of similar images, suggesting that two eyes are being used, we can see two images. However, you're going to see in a little while that you don't have to have two eyes to have diplopia. Therefore, this first definition, in my view, is not a good one. Of the four definitions that are presented here, probably the second one, diplopia is double vision, and that's all there is to it, is probably the easiest and maybe the simplest, and often simple things are the easiest things to remember and to understand. But what does diplopia mean, firstly, to you as a practitioner, and what does it mean to your patient? Many of you, or you, the person watching me, might have been a student of mine. And if you remember, I used to talk about sweat patches, and the more stressed you get, the bigger your sweat patches are. And sometimes those sweat patches go past your ankles and reach the floor. So a patient comes in and tells you, I started seeing double a week or two ago, or a day or two ago. And you start thinking, well, now what am I going to be doing? So diplopia, as far as you are concerned, could be life-threatening to your patient. It could make your life difficult. You might feel that you don't know what it is you're going to be doing for this patient to assist them. Do I refer? Don't I refer? So it is a situation that might be unfamiliar to you, and one in which you don't really feel comfortable. What does it mean to your patient? Your patient was walking along in the street, suddenly heard a strange sound in his head or her head, and started seeing double. They look up, they see your office, they walk in, and the first thing they're probably going to be is concerned about what is happening. They're confused, they don't understand what is happening. If they do have any understanding of what it means, they might realize that it has health and so health and in sometimes life situations, threatens your life. So for them, it is a stressful situation. They don't understand it. They're looking for your help. And are you in a position to be able to present them with that help? But that is not all. So diplopia isn't just double vision, and it isn't just what your patient or you experience, because there are many aspects, or so let's call them, what's the word I'm looking for? I can't even think of it. Let's go with aspects in terms of what diplopia can be. So firstly, diplopia can be monocular. So if you remember, we talked about that first definition where you needed disparity. Well, if you have monocular diplopia, it's in one eye and has nothing to do with two eyes. So you can have a two-eyed patient who has monocular diplopia, no variation in the angular deviation, in the alignment of the two visual axes. However, the patient still sees double. We have binocular diplopia. In other words, the first definition would be applicable in this instance, where there is a disparity and the two eyes, the visual axes, do not align perfectly with the object that the patient is looking at. Physiological diplopia. Every single patient who walks into your rooms, who has two reasonably functioning eyes, sees double and blurred all the time. The only things or objects or whatever it is they're looking at that is clear and single is what they're looking at. If they're looking at your nose, if they're looking at the word hello, or whatever the case might be, that and a small area around what they're looking at will be clear and single, and everything else is double and blurred. And that's easy enough to show for yourselves if you do not remember from second or third or fourth year or your experience in practice. All you have to do is stick up two fingers, look at the back finger, and the front finger is double, and swap your fixation around and the other finger is double. And that is physiological diplopia, something that every single patient with two reasonably well-functioning eyes is going to experience. However, most patients are totally unaware of the fact that they have this blurriness and the double vision. Diplopia, of course, can also be crossed or uncrossed. We all perhaps learned the rule that X is crossed. So a patient with an exotropia or an exodeviation is going to see crossed diplopia. However, that is only applicable if you are using a one-target test. For instance, a Maddox rod. One light gives you a light into one eye, gives you the cross to the other eye, and it is a single target test. Exo will result in crossed diplopia. However, if you're using something like pointed torches, or if you use a Brock posture board correctly in the applicable manner, then exotropia is going to be uncrossed. So depending on the type of test you're using will determine whether you've seen crossed or uncrossed diplopia. Therefore, the rule which says exo is crossed is not applicable unless specifically stated it's in a one-target test. We can have paradoxical diplopia. Usually, if you have, let's say, esotropia, and you slowly add base out prism and you neutralize that esotropia, the patient will have diplopia, which will get, the angle will get less and less and less until they're neutral. If you continue adding base out prism, you essentially make this individual an exotrope. So instead of having crossed or uncrossed in the esotropes instance and using a one-target test, instead of having uncrossed diplopia, they will then swap over to crossed diplopia, giving you a paradoxical or incongruous type of diplopia. One thing that isn't mentioned in any of the definitions that I've come across or the four that I presented you with is confusion. When you have diplopia, you have the doubling, or you're seeing two images of the same object. Confusion is when you have two different objects or two different images superimposed on each other. And whenever you have diplopia, you almost always have confusion at the same time. How do we, as a profession, find diplopia? Now, I want you to think a little bit carefully about this. You have a patient who's in your chair, who can do exactly what you tell them and can point and do certain things and respond to your questions relating to the test. Where's the green light, whatever the case is. But they can't tell you that they have diplopia or that they are seeing double. How many tests or what tests do you think we have to determine whether the patient actually does have diplopia? In other words, what objective tests do we have for diplopia? When I first started thinking about doing this presentation, I thought I understood diplopia a little bit, but soon realized that in fact, I don't know if I do, because I said to myself, if a patient does not tell me they have double vision, how am I going to find it? And after a month or two of thinking about it and discussing this with others, I've decided that I don't think I know how to do that. So I've thought of various tests, 1 target tests, 2 target tests, and come up with the conclusion that I'm not too sure I know of any test or objective test where the patient cannot respond to me and say, I'm seeing double, that I would know whether they have diplopia or not. And I don't know if any of you have thought of any tests, and you can perhaps let me know via email or whatever the case is, what you've thought of. But I certainly have not been able to think of a test where I can assure myself that the patient has diplopia without the patient actually telling me they have diplopia. So as far as I'm concerned at the present time, only the patient knows if they have diplopia or not. And we have to rely on what our patient tells us to determine or to decide whether they actually have diplopia or not. And another way to put this question is, if a patient states that they have double vision, can you prove, or let's call it, can you prove that they don't? I certainly can't. So our patient sitting in our chair has now informed us that they see double. And you need to remember that very often, in fact, you should, in every single patient, ask if they have double vision or not. Because patients will often sit in your chair and not tell you what it is you need to know. And sometimes they'll tell you, oh, I'm perfectly healthy. But they'll pull out a list of medications that have like 20 medications on them, or they'll have a touch of diabetes every now and again, or whatever the case is. So you need to be careful and make sure that you ask your patients the appropriate questions. And in this instance, do you have double vision? Once they say, yes, I have double vision, you then need to determine whether it is true diplopia or more of a ghosting type of diplopia. And the way I would normally do that is to say, do you see double like this? Or do you see double that's more like a ghost, a blurry kind of little cyst, a little blurry patch next to the thing that is supposed to be double? You need to make sure that you are in fact dealing with diplopia and not ghosting. Very important is to find out whether the onset of their diplopia is sudden or it's been long-standing. They might say to you, well, I've had double vision for the last 20 years, or 3 days ago, I got hit in the face and all of a sudden I have diplopia or I have double vision. You also need to try and find out whether they have binocular or monocular diplopia. Do you close one eye? And that's why I added it to the title of this presentation. Do you close one eye? Because if you don't, patient says I have double vision, and you do not check one eye and then the other and see whether that diplopia is present in one or other eye or has only present when both eyes are open, you're not really going to know what you're dealing with. So you need to close one eye. Is the diplopia there or not? Close the other eye. Is the diplopia there or not? And then open both eyes. And is the diplopia there or not? And you'll then be in a position to begin deciding what it is you're going to be busy with. In the back of your mind, you should always be thinking about, is the diplopia that the patient is presenting with pathology related? We will talk in a little while about some of the pathologies, but I'm going to tell you right now that some of the pathologies related to sudden onset diplopia are life-threatening, as you probably know, and your patient will not appreciate if you miss this nor their family, nor their lawyers, and all the rest that comes with the lawsuits and all the rest that comes in courts. And the lawyers will have months to figure out what it is you did wrong, and you've had maybe half an hour to decide what your patient's problem is. Is the diplopia intractable? In other words, they've got it, they've had it, and nothing gets rid of it other than occluding one eye. So the exercises, they've tried therapy, they've tried surgery, they have the diplopia, and it is there, and there's nothing they can do about it, and it's constant and permanent. Are both images clear? Always one blurry? Because if the diplopia that the patient says they have is in one eye only, and it is related to some kind of optical anomaly or whatever the case might be, you might find that the one image they see is clear and the other one is blurry. And in a little while, I'll give you an example of an instance where this might be the case. And then lastly, you need to find out whether the strabismus, we suspect if it's a two-eyed type of diplopia, and strabismus really is present as soon as those two visual axes do not meet at the same point. Is it competent or incompetent? And we're going to be talking about that in a little while, and how you try and find out whether it's incompetent or not, and the significance of whether the strabismus is incompetent or not. You've probably all heard this before. It's nothing new, but sometimes we forget this. We're busy in practice. We've seen 5, 10, 15 patients, whatever the case might be, and we sometimes forget what it is we should be remembering, the important things we should be remembering. In fact, I read a brilliant book by a guy called Atul Gawande called the Checklist Manifesto, and they're now introducing checklists into surgery. When doctors, surgeons are doing their surgeries, they have checklists. And it's got to the point in some hospitals where nurses can stop the surgical procedure and say, "Excuse me, doctor, but did you remember to give the patient the antibiotic that they required?" And they have found that the number of mistakes being made have been dropped or reduced dramatically, because they're actually going through checklists. And these are more important in emergency kind of situations where everybody's under pressure. There's 10 patients in the ER and somebody forgets something. So Checklist Manifesto, a good book to read, Atul Gawande. So going back, anything with a sudden onset should be alarming. It's going to be alarming to your patient. They've had the sudden onset of diplopia. They don't know what's going on. They've got these two images. They might feel dizzy. They might feel confused, whatever the case is. And of course, as we've discussed, it should be alarming to you as well. So let's talk a little bit about monocular diplopia, where diplopia exists in one eye. And this is where you need to close alternate eyes. And is the diplopia still present? First thing is, you're now in a position to start looking and finding, trying to find out what the cause of this monocular diplopia might be. So slit lamp. Things that can cause monocular diplopia: corneal scarring. Patients, excuse me, have had some kind of trauma, or whatever the case might be, and a scar can diffract or refract or scatter light and result in seeing double. Ectopia lentis, you should be thinking of the condition which is commonly associated with this particular problem. Ectopia lentis, dislocated lens. This is an instance where we talked earlier about, is the image, or is there one image clear and one image blurred? Because if the patient is seeing through the lens is not dislocated to the point where it's completely out of alignment, they might have a clear image and a blurred image at the same time. One image being created through the lens and the other image being created around the side of the lens. So that is something you need to be a little bit aware of. Of course, the condition that I'm referring to is Marfan syndrome, arachnodactyly, length of arms from tip to tip, like from left to right, tip to tip, is longer than their length. They have heart problems very often, so something that you need to keep in mind. Contact lenses can cause diplopia, or blurring in one eye. What about tear layers, which start drying up on the surface of the lens? Does blinking make a difference to the diplopia? Does moving the lens, cleaning the lens, those types of things make any difference to whether they have the diplopia or not? Keratoconus and Orectasia, perhaps the same thing in some instances. In many instances, keratoconus is an ectasia, but ectasia doesn't always have to be keratoconus. And there's a nice article in the Review of Optometry, August in 2019, which goes through some of the causes of the monocular diplopia. Lens opacities can scatter light, once again causing the patient to perceive double vision in one eye. Polychoria, multiple pupils. I don't really understand this completely, because when I was a student, I remember a thing called shyness principle, where you could have a disc with holes in it and still measure the power of a lens through it if you put it in a vert, even though there was no direct transfer of light from the one side of the vert to the other. All the light passed through the little hole, so something like that. I don't understand how polychoria perhaps creates this, if shyness principle is applicable. Tearful drying, too much oiliness of the tears, debris in the tears. Chen, Mayo Clinic, suggests that tearful can create monocular diplopia. Refractive state, we have anisometropia, we have plan in one eye, -3 in the other eye, and we decide to try and fit this patient in spectacles, whatever the case is, and up until this point they've had monovision and they've been perfectly happy. We come along and in our infinite wisdom we decide we're going to give them a pair of spectacles, and all of a sudden they have diplopia. Spectacle lenses can be tilted. The pantoscopic angle obviously is different. Spectacle lenses can be tilted, more or less curved around the face, causing difficulties for patients to have single vision sometimes. Then, of course, there's different types of retinopathy that can result in monocular diplopia as well. So those are some of the things that can cause monocular diplopia. You should be able to find or understand the cause in most of these instances with a slit lamp and questioning your patient and doing your refraction carefully and ophthalmoscopy and those different types of things. So what do? The patient's sitting in your chair and they have monocular diplopia. Well, you either refer it or you treat it. If it is keratoconus, you fit them with a rigid lens, or you have semi-scleral lens, or whatever the case is, or whatever you think is appropriate, and you compensate for their keratoconus, and that monocular diplopia might well go away. If it is corneal scarring, you need to refer it. They might need a keratoplasty. If it's retinopathy, obviously refer it. If it's tear layer problems or contact lens problems, the surface of the contact lens is dirty, it's oily, it hasn't been cleaned, you know what to do about that. And you can assure your patients and keep them happy. Make sure that if it's needing referral, you do that. If the patient has Marfan syndrome and they've got Ectopia lentis, let them go and have their lens taken out, and monocular diplopia will be eliminated. So there are many instances where monocular diplopia can be treated directly by you, and where appropriate and necessary, you need to refer them to the appropriate medical practitioner. So let's talk a little bit about binocular diplopia, remembering, of course, that the cause of binocular diplopia of sudden onset can be potentially life-threatening. There are conditions which will cause sudden onset binocular diplopia, which can kill your patient. And that you need to keep in mind. I don't know how many of you are going to feel happy if, in fact, you miss something like this and your patient actually does die. And I can relate a case or two where patients have died, and I might remember to tell you that in the future, in a little while. So you have a patient come in and have sudden onset diplopia, and you've now determined that it's not monocular, and you now need to figure out, is the cause of this binocular diplopia incompetence? So here's the definition of incompetence. The condition in which, and I'm not going to read it for you, the condition in which you can read it yourself, but there are two things here that are important. The one is according to which eye is fixating and in which direction the eyes are looking. So essentially, the angle of deviation changes for different directions of gaze. Or if you swap fixation from the non-strabismic eye to the strabismic eye, in other words, you're going to be measuring the primary angle and then the secondary angle, you're going to find that the primary angle and the secondary angle are not the same. And usually they need to be different by about 5 prism diopters. As soon as your primary angle and your secondary angle differ by more than 5 prism diopters or thereabouts, you have an incompetent strabismus. Or if your angle of deviation is, let's say, ortho when looking left and 25 exo when looking right, that is incompetence. And this is where you really need to be careful and make sure you understand what is going on. And you please need to remember this little bit about when the eyes are looking in different directions, the angle changes. I will discuss that in a while. So you now have decided that you have this patient, they have double vision, it's not monocular diplopia, and now you need to start trying to find out what is going on. So as usual, the first thing we do is a case history. You need to know the onset. When did this diplopia start? Was it yesterday, last week? It's been there my whole life. It's followed surgery when I was 7 or 8 or 9, whatever the case is. It's important to know this. Once again, anything of sudden onset should be alarming. Alarm bells should start ringing. You need to ask your patient about trauma. Any trauma to the head, to the eye. Have they been punched? Have they been hit on the head with a baseball bat? Were they involved in a motor car accident? Did they fall off a bar stool and hit their head? Did they trip and hit their head? You need to know about any type of trauma above the neck, essentially. And maybe in some instances, maybe not even, but usually above the neck. So you need to be asking the questions. Patients often are not going to tell you this is what has happened. You need to ask always. Does the patient have any transient ischemic attack type symptoms? Do they have numbness in their hands? Do they have pins and needles? Do they have numbness in their mouth? Are they able to speak and pronounce and enunciate words the way they would normally be able to? Do they have photopsia? Do they have floaters that were not there before? Do they have amaurosis? These are the types of questions that you need to be asking, because if your patient's diplopia and incompetence strabismus is because of a CVA, stroke, they might well have had TIA type symptoms before the onset of their stroke. So you need to be asking these questions. Is the patient diabetic? Are they well controlled? What is their HbA1c? Have they been seeing their medical practitioner regularly? Because I've had patients who've said to me, oh, I'm diabetic some of the time, and I know it, I feel strange, and when I feel it, I take my insulin or I take my medication. That's like saying, well, occasionally I think I'm pregnant, but not always. You can't be half pregnant. If you have type 1 diabetes, you've got it. It's there probably for the rest of your life. Patients need to understand how nasty a disease diabetes is. And diabetes can be a direct result of incompetence strabismus. You need to do monocular and binocular motilities. Does the angle vary in different directions of gaze? You're looking for incompetence. So by doing monocular and binocular motilities, if the angle of deviation is of a fairly large amount, you will then be in a position to pick that up just by looking at your patient. You can measure the cover test, different directions of gaze. You can use a synoptophore. You can use a Brock posture board. Then there are many ways in which you can measure the angle of direction in different directions of gaze and then start figuring out that in fact that angle is changing when patients look in different directions. We talk about incompetence strabismus, but we also need to, when we're doing our case history, we need to start thinking about what about near-work related problems. Patients, I'm sure you all see them. I'm sure you all see them every day. They sit in front of a computer for 8 hours at work. They have few breaks. They then go home and they might continue with their job on a computer, or they get home and they pick up their smartphone and they start chatting to their friends on Facebook, Twitter, Tweet, Yellowberry, Blackfeet, all these strange things related to smartphones that I don't know anything about. I'm technophobic. Some of you might remember that. I'm still technophobic. I still can't work these things properly. But your patients know. And young patients cannot be excluded. Young people are spending amazing amounts of time sitting in front of computers, tablets, and smartphones. They watch movies on smartphones. Something like 57% of 1,200 kids in Johannesburg and Pretoria, I think it's 57% of them have been exposed and watch porn on their smartphones. It was a study done by a group at UNISA. The numbers are quite frightening, and you can look at any literature related to these types of things. You'll find it's happening all over the world. What about the effects of fatigue? I start reading my book, whatever the case is, and 2 hours later I have diplopia at near. Rest, it goes away. You need to be asking these questions. Does the patient have UTOP sign, where the symptoms they have and or the signs they have get worse when their body temperature goes up? So often they get into a warm shower and all of a sudden they will then start seeing double. Do they have any major illnesses, cardiac problems, hypertensive problems, as we mentioned, diabetes, sickle cell disease, whatever the case is? You need to be asking the questions related to the type of thing that can give you more information about why your patient has this diplopia that they're now seeing you about. We can then start looking at primary versus secondary angles / different directions of gaze. What tests can you do to try and get an idea as to what is actually happening with your patient? So the first one is, you've probably heard of this thing. Most of you might not have done it in the last however many years since you qualified, but you don't have to plot an exact hair screen to figure out that your patient has incompetent strabismus. So if you do want to do a detailed, well-plotted hair screen, you're perfectly welcome, and you'll be able to say that it is the right superior oblique. I'm not too sure that you need to know that, because you're not going to be doing the surgery. You're not going to be looking at the MRIs or the CT scans and figuring out just where is the problem. Your job is to find the incompetence. So what you do is, you've got red-green anaglyphs, you've got a red and green pointed torch, 1 meter from the wall, put your patient into your anaglyphs, give them one torch, you hold the other torch, and you point them in 9 directions of gaze. And if the separation of the red and the green light, one you're holding, one your patient is holding, if that separation changes significantly in different directions of gaze, your hair screen has just told you that that patient has got incompetent strabismus. And you do not need to go and spend an hour or two trying to plot the hair screen exactly. That is, I would say, not necessarily your job. The next thing you can make use of, another simple test, anaglyphs and a torch. In both the hair screen and in the diplopia field test, you have to ensure that your patient, however, keeps their head still. Because if they're going to turn their head and look at your lights, they might well be ortho wherever they look. So they need to keep their head still and move their eyes into 9 positions of gaze. And then you're going to pick it up if it's there. So diplopia field test, easy. Patient's got anaglyphs, white light in front of them, white torch in front of them, 9 different positions of gaze, and you ask the patient, is the separation of the red and the green light changing when you look left, right, up, down, and so on? Of course, you have to have diplopia for this test to work, and we would not be doing the diplopia field test if there was no diplopia. We can make use of the synoptophore and or the Brock posture board, and there are many others. Synoptophore can measure just about anything you need to measure. Fixation disparities, anomalous correspondence, primary angle, secondary angle, you name it, stereops, whatever. This thing can do everything. However, it is limited in that it is all at approximately 40-50 centimeters from you. And of course, they cost a lot of money, and you can do everything you need to without the synoptophore. But if you have a synoptophore, you can then do all the testing that you need to do. Something simple like a Brock posture board can be used to measure primary and secondary angles. Swap the anaglyphs around, measure the angle with one, swap it around, measure the angle with the other. You've just measured primary versus secondary angle, and if that angle is more than around about 5 prism diopters different, that patient has got incompetent strabismus. Simple test, direction of gaze, motility. How many of us, and I'm talking to you, do you do motility on every single patient? If you do not, you should, because it is a simple test and it will immediately tell you whether the patient has got incompetent strabismus or not. And it must be done monocularly and binocularly. Internuclear ophthalmoplegia binocularly will show limitations of gaze. So you're going to pick up a limitation of gaze and you're going to think, aha, there's something wrong with, let's say, the medial rectus. If you do motilities monocularly, you're going to find that let's say, the right eye, the right medial rectus functions perfectly well. And if you do convergence, near point of convergence, both eyes will converge. So this is an instance where binocular motility versus monocular motility will give you a very good, let's say, indication or direction to think in terms of what is going on with your patient. You've all heard of Bielczewski's head tilt test, also known as the Parkes three-step test. You've got 3 steps to it. You do cover test. You find out which 4 muscles can be resulting in a vertical strabismus, and this test is applicable to vertical strabismus only. You then measure angles left and measure angles right, and you've eliminated 2 of those muscles, and then you get them to tilt the head this way, and you measure the angle, and you measure it that way, and you measure the angle, and the side to which you have an increase in angle gives you the muscle. You can eliminate that 3rd muscle. There are little, let's call them mnemonics, which you can use, where you've got a little chart in front of you with all 6 muscles in each eye, and you start circling different ones and different things to do. I don't even know how that works, but when you're done, it'll tell you which muscle is the muscle that you need to suspect as being paretic or paralytic. Maddox rod, you can do a Maddox rod, directions of gaze, quick and easy, get the patient to look left, right, back, and whatever the case is, and it'll tell you that there is a difference in perceived separation of the rod and the light. Hopefully, everybody is doing cover tests on everybody, on every patient. Because if you do not do a cover test on every patient, you have no idea whether your patient's strabismic or not. Because it is probably the best and or perhaps the only significant test to decide whether a patient in fact has a strabismus versus a Fourier, dissociated Fourier. Cover test needs to be done on every single patient you see. Let's hope we're all doing that. Of course, there's past pointing. If a patient has incompetent strabismus of recent onset, they are going to have difficulty figuring out where something is out there in space. So what you do is you will hold a page in front of the patient and you'll hold a pen behind the page. They're going to put their hand on their nose and you say, right, touch the pen. And they're going to reach out towards the pen and they are probably going to go past or stop short of the pen and then realize they've made the mistake and they're going to come back. Because as I understand it, their whole proprioceptive system feeding back to them where things are in space without having to touch it is upset a little. Because the eye with the paresis, the musculature and the neurology feeding those muscles and the feedback systems are now being told different things. The muscles think they're looking somewhere where in fact they're not, and giving your brain information, and they're going to then go usually past and then come back, called past pointing. These are some of the things you need to be doing if a patient walks in with diplopia, and this is how you figure out whether they are incompetent or not. It's an important thing to make sense of and to know whether you have it or not. Some of the causes that cause incompetent strabismus. Trauma being a common one, blowout, fracture. Patient gets punched in the face, they have the floor of their orbit gets damaged, muscle gets hooked up in the crack or the hole or whatever the case is in the floor of the orbit, and they all of a sudden have incompetent strabismus. Hemorrhaging to the brain, perhaps around nerves, perhaps the nuclei, whatever the case might be, they are going to have incompetent strabismus. Pressure, increased intracranial pressure can result in incompetent strabismus, not specifically, but quite commonly of the 6th nerve, because the 6th nerve goes over a little piece of bone called the clevis. And if your intracranial pressure is increasing, it presses the brain basically down and then applies pressure to the 6th nerve as it goes over the clevis and then starts inducing pressure to the nerve, which then starts resulting in paresis of that particular nerve. Neoplasia, tumors, different tumors can happen many places, all over the place. That is a common cause of incompetent strabismus. Vascular and or cerebrovascular accident, hemorrhaging, aneurysm, thrombosis, you can read the list. An interesting talk was presented by Dr. Gareth Fernandez about 6 months or so ago about a patient that woke up, had double vision, he had a drooping lid, and was a diabetic patient, if I remember correctly. went to his GP. The GP wasn't too sure what was going on, referred him to a neurologist. The neurologist chose to refer the patient to Dr. Fernandez. After 4 hours, I think the patient was seen by him. He was the first doctor to lift the lid and see that the pupil was blown, suggesting an aneurysm. I think it's of the posterior communicating artery, and I think that patient died later that afternoon because everything was just sort of missed, perhaps, and who knows why or how. But here's that case I said, well, I'll tell you where patients die because of the causes of the incompetent strabismus that you and I need to be looking at and being careful of. Multiple sclerosis, many instances, the first symptoms somebody with multiple sclerosis are going to have or is going to have is diplopia. Myasthenia gravis, same thing, often results in diplopia. Thyroid, Graves' disease, the exophthalmos that comes along with it causes restrictions of the muscular movements in the eye, result in diplopia. Diabetes, we might all have heard of if you have a sudden onset third nerve palsy in a diabetic patient and the pupil is spared, don't panic. If, however, the pupil is blown, panic. Well, when I first started learning about this thing several years ago, I downloaded several papers in medical literature looking at the need to worry about whether the pupil is blown or spared. And everything I read, if you have a diabetic patient who walks in with a third nerve palsy, whether the pupil is blown or not, you refer them. Because all the literature that I read said the only way to really make sure that there's nothing going on inside this patient's head is an MRI. So don't think, oh, well, look, the pupil is not blown, patient's diabetic, oh, well, that's nothing to worry about. It's ischemic, and it's definitely not that aneurysm of the posterior communicating artery. Refer. It's not our job to decide that this patient doesn't have life-threatening disease. Let the people who are trained to do that job, and not us. Internuclear ophthalmoplegia, trouble with the medial longitudinal fasciculus. Again, that's where you're going to definitely pick this up if you've done monocular and binocular motilities. Neurological problems, meningitis, there are many of these things. About 2 or 3 months ago, I realized that I had diplopia, looking up and to the left, when I was busy stargazing. Some of you know that I'm very interested in astronomy, and out here where I live in Hoedspruit, the sky is beautiful, and I realized I'm seeing double. So 20,000 Rand later, MRIs, all the tests for myasthenia and all these different things came back negative. It's not getting worse. Idiopathic, I don't know. Hopefully there's nothing strange going on inside my head, but certainly off you go and have the MRI. Leonie saw a patient the other day, a couple of weeks ago, young man, 38, sudden onset diplopia. First thing, MRI, all these tests, and nothing wrong. But it's not for us to decide that. We need to refer these patients and let them be assessed properly. If somebody has sudden onset diplopia, it's almost inevitable, I think, that either the neurologist or the ophthalmologist is going to require a scan of that patient's head. Sagging eye syndrome, it's something I learned about 6 months ago. Again, Dr. Fernandez was speaking about this on a little webinar that he did. And it's an interesting thing, this. There's a nice paper, it's in the American Journal of Ophthalmology, published this year by Gosecki. You can see the reference there. Some nice pictures of what happens to the extraocular muscles in this condition. And instead of the extraocular muscles being sort of on either side, laterally placed of the eyeball, they end up moving down because there's a pulley type or a ligament type connection between various muscles, and that pulley ruptures, and in this instance, the medial and lateral recti move down. So instead of working horizontally, they start working sort of half horizontally and half vertically, and it induces vertical diplopia. So the commonest cause of vertical diplopia in those older than 65 is in fact sagging eye syndrome. The study looked at 945 patients over 65, and 31.4% were due to sagging eye syndrome, something I only learned in the last few months. So hopefully that's something that is new to you. And you can, this American Journal of Ophthalmology is available. I think I found it in Google Scholar. What to do? If it is of recent onset, you refer this patient. You don't start thinking, well, it'll get better or they'll grow out of it, or whatever the case is. If a patient has sudden onset incompetent diplopia, you refer it. I don't think there's any more to worry about. That's the story. If it's long-term, we had patients in the clinic when I was still lecturing, a young girl who had surgery at I think 7 or 8 or 9, and a gentleman who had the same thing. He had intractable diplopia for I think it was about 50 years. He hadn't learned to suppress. He had double vision all the time, and the young girl did as well. So if it's not sudden onset and a patient presents with that type of thing, you're going to handle it perhaps differently. If they have Brown syndrome, what can be done about it? Perhaps some surgery. Do they get used to it? Do they get over it? Whatever the case is. Same thing with Duane's retraction syndrome. What do you do with a patient who has diplopia, who's been through the ophthalmological treatment and or assessment and been through the neurological assessment, and their diplopia is not getting better? They have double vision. It's driving them crazy. They've been seen by the specialists. There's no active pathology. What are you going to do? Are you going to say, well, I don't know what I'm going to do? If it was you, would you like that type of, let's say, approach by the professional you are seeing? I don't know what to do about it. I guess get used to it, whatever the case is. But there are things you can do about it. Patients don't like these ideas, but you either have double vision or you perhaps do one of these things. So the one easy way is occlude the eye. Occlude the turned eye. You can swap that around so that they can use their one eye and then the other eye. However, if they have a paralyzed eye, paralyzed in terms of cannot straighten, then you cannot swap fixation. But if they can, perhaps they might want to try and alternate the occlusion. But what works really well is clear nail varnish. You paint clear nail varnish onto the lens, onto the back surface of the lens, of a spectacle lens, and you dab it with a nail varnish brush until it gets all gooey, and they cannot see through that. But when you look at the patient from an observer's point of view, you can hardly notice that there is this occluder. A frosted lens is much more noticeable. So clear nail varnish works well. If it doesn't work, bit of acetone and it's off and nobody's lost anything. Sellotape has been used in the past. You can use a contact lens, blur the eye out, but then of course you've got all the rigmarole that comes with contact lenses and increased infection rates and the whole hassle factor of contact lens wear. Is it necessary? I've had numerous discussions and arguments with people and past students. Oh, I had my patient, they had incompetence strabismus, and I'd give them a prism and it's sorted. Well, I really do not make much sense of that. If you say to me, sitting at a computer, 40 centimeters away, head in this position, computer in that position, I can give a prism which will give that patient single vision. But if it's incompetent, remember the definition, the angle changes for different directions of gaze. If they have incompetence strabismus, a single prism power cannot neutralize or compensate for the strabismus that that patient has. Unless, of course, I'm out of optometry mostly now. Perhaps they exist. I have not heard of them yet, but I've not heard of very prism, where we can have prism changing power as we change direction of gaze. It doesn't exist. So how do you explain the fact that when you put up the prism, the patient's double vision is gone? Perhaps it makes vision so blurry that they are unable to see well, and they're able to suppress that eye easier through the prism. I don't know, but you're not, with a single prism power, you cannot be compensating for the varying angle, unless I'm missing something. The other thing you need for these patients who have long-term diplopia is empathy. You need to try and understand how they are perceiving their world. It's like these patients who have a single little eyelash that starts growing and scratches their cornea. We all think, oh, well, I can just yank it out or whatever the case is. How bad can it be? Well, I don't think it's that simple. These patients, I think, are very frustrated, and I think their quality of life is affected quite severely by the fact that they're having intractable diplopia. So don't just write them off and say, oh, it'll get better or get used to it. You know, go away, you'll get used to it. I don't think it's that simple. I think we really should try and get rid of this condition for these patients. Is it comitant? If it's comitant, they have diplopia when they read and they're fatigued, or it's near point of convergence related, or there's some kind of accommodative vergence, or there's a convergence insufficiency. You know how to measure these things and how to detect them. Well, then you can detect it and treat it. Big difference is it is comitant versus incomitant. What do you do when you have a comitant strabismic, or a comitant, not let's call it strabismic, but a patient who develops an intermittent strabismus due to near work, intermittent exotropia, poor NPC, whatever the case is? Well, first thing we can attempt is vision therapy. And you all have been through 4 years of optometry school. You should have an idea of what to do. PhD 1, 2, and 3, voluntary vergence, Brock string, base out and base in reserves, BIM, BOP, all those different types of things that you can look up easily on the internet and or in a textbook. You can prescribe prism. In my view, I hardly ever prescribe prism. And I've had arguments with students and non-ex-students on numerous occasions. I personally do not use much prism. Rightly or wrongly, I don't know, but I would rather go with vision therapy than prism. You need to give your patients advice. That's your job. You need to be telling people who sit in front of a computer that they need to take regular breaks. That means every half an hour. All the literature is clear. You need to take regular breaks. In some instances, they need to wear their spectacles. They need to limit their near work. Good luck with that if you're busy with a child who sits with a phone at this distance all day, etc. You need to talk about working distance. How far should they be working at? And in terms of computers, between 50 and 70 centimeters should be optimal. But a problem I'm finding recently is patients come into the office, and when I was locuming, they'll come into the office and say, oh, well, I don't have one screen, I have 4 or 5 or 6. Now what? Now my sweat patches start hitting the floor, because now they're sort of early presbyopes and they've got screens left, right, and center and above them. How do I sort this problem out with one pair of spectacles, and with the limitations of varifocals and multifocals and bifocals? For me, it's a huge problem. Another huge problem is screen time. Do yourself a favor and Google screen time. You will have probably hundreds of thousands of hits. There's a good book called Glow Kids. It's all about children and spending too much time in front of computers and iPads and all these different types of things. There's a lot of literature on screen time being related to myopia. You should know that myopia is becoming a huge problem around the world. It's becoming an epidemic, pandemic, where more and more people are becoming myopic, and we do not really understand why. Screen time is thought to be one of those problems. Screen time, spending time in front of smartphones, and in turn in front of computer games, and in front of tablets, and these SPSs, Sony PlayStation boxes, and all these different types of things. There are problems, so psychosocial, academic, in terms of myopia. There's addiction. Kids are becoming addicted to pornography. I think there's a game called I can't even remember the name, Not Serious. These children are having huge problems with spending far too much time in front of screens, especially small ones. And they watch movies on an iPhone or on a smartphone. I don't even know how they do that. They should limit their screen time to a maximum of 2 hours a day. Well, good luck with that. I say good luck to any parent who's going to try and stop their child spending more than 2 hours looking at a screen. And if you take away their cell phone and or they take away their tablet, they're just going to go next door and they're going to sit with their friend. And if you think you can lock it, well, their little friend will unlock it. And you really do need to be aware of what your kids are watching and who they're talking to while they're busy with their screen time. It's a huge, huge problem. So I hope that I've been able to refresh your knowledge a little bit. I hope that I've been able to show you 1 or 2 new things about diplopia. I certainly had my eyes opened, I think, when I realized that I could not come up with any test, objective test If a patient cannot respond to me, I don't know if they have diplopia. And hopefully you will have perhaps what I've now called a binocular view of diplopia. That's all I have to say. I hope that you have a pleasant evening further.